morning, colleagues, and welcome to each and everyone that are here, both the colleagues that are here as well as those who are online. We have a group of our colleagues who are joining us online via Zoom. It's such a pleasure, to see you all here after COVID. I know some of you, they were bringing the elbow. I'm like, no, I'm not taking the elbow, I'm hugging because I've been deprived of that human touch for a long time. So thank you so much. And what a coincidence that on the very first time that we're meeting together, we are meeting this amazing doctor who brings the whole world together through his initiatives. And he's actually brought us together again at UKZN to meet, because most of you haven't met for almost like 2 years. So I'm not going to waste time, but I'm going to introduce Dr. Sanjeev Arora, who is a gastroenterologist by profession and is the founder and director of the project ECHO. So ECHO stands for Extension for Community Healthcare Outcomes, which is a globally recognized disruptive innovation that tackles the world's greatest challenges by providing access to knowledge and best practices in health, education, and other domains for rural and urban underserved populations. So you guys will note that we only got to know about Zoom and the online platform after COVID. This gentleman here has been doing this for years. This was first developed in 2003 to respond to the growing hepatitis C crisis in New Mexico, where he comes from. The ECHO model has since expanded to address over 70 disease areas and other complex issues at over 520 training centers in 56 countries in the world. So Dr. Arora is also a Regents and a distinguished professor of medicine with a tenure in the Department of Internal Medicine at the University of New Mexico Health Sciences Center in Albuquerque. I don't know if I said it correctly. So colleagues, it's really my pleasure to introduce Professor Arora. He's going to talk to us about the ECHO project. But before I even ask him to come on stage, I want to acknowledge a few colleagues of ours who have been my pillar of support in terms of establishing the ECHO project. We started this beginning from last year, and we're having Zoom meetings to see how we can establish the ECHO project in KZN, South Africa. I was also fortunate to get funding from an NGO, the Healing Project from Unilever, which is based in California. They wanted to know how they can assist us, and I said to them, you know what, if you can assist us with revamping one of the offices so that you can have an ECHO room where everybody has access to. So they gave me something like 150,000 rands to renovate the ECHO room that you've just been to. So that's an NGO called Direct Relief, which works with Unilever. It's a company that I am close to in terms of no conflict of interest, actually, but because I'm a dermatologist, your toothpaste and your moisturizers come from there. So they were grateful. So I am going to ask the following colleagues, those that are here, to just stand up, because they are the colleagues that made it possible for me to establish the ECHO project and also to have Professor Arora here today. Without them, I would not have been able to establish this project in KZN. The leader of the project is obviously my young lady here on my right, who is Dr. Cyrilla Ramklas, who I appointed to run this project because of her passion for outreach and community service. And I'm sure you have seen that as she was conducting you and walking around. So I'm so grateful to Cyrilla, because I couldn't do this on my own and all the other responsibilities that I have. The second person I want to acknowledge is Professor Len Murray, who's orthopedics. He's not here, but he's always been there for our lunch Friday meetings. Dr. Farana Parouk, she's not here. She's a rheumatologist. Professor Eunice Musa, could you please stand up? She was also part of the committee, yes. Dr. Anton Rocha, there he is, our young gentleman there, who's an orthopedic surgeon, very passionate about outreach. You can almost feel it, you can almost touch it, almost palpable. And then we have Professor Bernard Dede, he's not here. And we have Mr. Sivato Madikiza. He's also not here, but he's the technical brains behind what we need as the echo center rooms and the echo peripheral areas. So he went to all the hospitals that we wanted to start with to see what is there in terms of infrastructure, and then reported to us. And then Dr. Zamambo Mkize, who's a dermatologist, but he's based in Maritzburg. He couldn't come. Have I left anyone? And of course, last but not the least, our Ishana, who is there as our administrator, coordinating all the meetings, arranging everything. Have I left anyone, Cyrilla?
Dawood.
Oh, Dr. Dawood as well, yes. She's not from Maritzburg. She's not. If I've forgotten anyone, please, my apologies. But colleagues, without further ado, please, I'm going to hand over now to Cyrilla to just say a few words about what Professor Aurora has done, so that you have an idea of what this amazing colleague has done for the world. Thank you so much.
It's fine.
Okay.
Okay. So thank you, Prof. So ECHO goes by the slogan, move knowledge, not people. And ECHO is a free, globally recognized model that uses virtual case-based learning with subject matter experts assisting clinicians in rural and urban underserved areas to reduce health disparities. So you've heard from Prof. Glover that ECHO was developed in 2003, and it has grown extensively globally. And it has, it covers a range of complex diseases, including diabetes, heart disease, cancer, COVID-19, hepatitis C, and HIV. More than 300 publications attest to the effectiveness of ECHO, including a landmark publication in the New England Journal of Medicine. I must say this as well, that in 2020, Project ECHO was one of 6 finalists in the John D. and Catherine T. MacArthur Foundation's 100 and Change competition. The competition funds a single proposal that promises real progress in solving a critical problem to the tune, listen to this, of $100 million. Yeah. In 2021, Dr. Aurora received the Brock Prize in Education Innovation. Congratulations, Dr. Aurora. Welcome. We really applaud your success with this project. And Dr. Aurora is here today to promote the role of ECHO in community outreach. Dr. Aurora.
Thank you. First of all, thank you, Dr. Ramklas, for organizing this. But my special thanks to Dean Delova, that just my brief stay here, I'm so inspired by your leadership. First of all, to create such a room for physicians to come and relax in, that's a wonderful contribution in itself. It's hard to find these, at least in academic hospitals in the United States. And thank you for the ECHO room, but also thank you for your leadership I visit, a lot of universities all over the world, and it's not easy to find a dean who really adopts community service at the heart of their mission. And so thank you for that, and thank you for this opportunity to talk to you. And it's a special honor for me to be here, because this is the Nelson Mandela School of Medicine. It's a human being I've admired for a very long time. And so as I go there, before I tell you about ECHO, I have to say that, one of the people why Durban and South Africa is so important to me is the works of Mahatma Gandhi really inspired me when I was a kid and as a young adult. And one of his quotes was that if you want to find yourself, you must lose yourself in the service of others. Somebody here must have heard this quote before.
Yeah.
And I was in my career, I went to the United States in 1980. I wasn't born there, and I was about around 1993 to 1990, I started saying I have to find myself. And that's where I also came up with a quote from a Nobel Prize winner who actually worked in Africa. His name is Albert Schweitzer. and he got the Nobel Prize, and he said something that really touched me. He said, I don't know what your destiny will be, but one thing I do know for certain, that the only ones among you who will be really happy are the ones who have found and served other people. So this was, I read this quote, I'd already seen Mahatma Gandhi's teachings, but really what struck me was that he was saying exactly, there was one key word in both of these phrases, and the word was only. Mahatma Gandhi said, the only way to find yourself, there is no other way. And Albert Schweitzer said exactly the same thing. So of course it got me thinking, I've got to figure out a way to serve others rather than serving myself by getting more degrees and getting more specialties, etc. So the year was 2001, and I went into my clinic, gastroenterology clinic, at the University of New Mexico, which is a country in the southwest United States. It's located between Arizona and Texas, just north of the country of Mexico. And on the north of us is the state Colorado. So that's where we sit. So I walked into my clinic, and there was a 43-year-old woman there. And there was a 14-year-old boy sitting with her, a 9-year-old girl, and I asked her, how can I help you? And she said, I have hepatitis C, and I want treatment. I said, fine, that's what I do. I'll treat you. How long have you had it? And she said, I've had it for 8 years. So when did you get it? She said, I probably got it at the age of 16 when I used some drugs. So she'd had it for almost 27 years at this point. And so I said, but when did you find out you had hepatitis C? She said, I found out 8 years ago. So I said, why did you not come earlier for treatment? And she said, I called your clinic, and there was an 8-month wait to see you. And I needed this treatment of what we call interferon and ribavirin. These were these injections and pills which were quite toxic. And there were no primary or family doctor was giving interferon ribavirin at that time in New Mexico. Not a single one had ever treated hepatitis C. And she called my nurse. My nurse said, you'd have to come to see Dr. Arora 12 times, once a month, while you were getting these injections and pills. And she said, I'm a single mother. I live 200 miles away. There was no way I could come this many times. I was tired, but I could still keep working. I needed to work. So I said, why did you come today? And she said, I'm having pain here in my right side of my abdomen, right here. And hepatitis C, there's one GI doctor in the room, knows that hepatitis C doesn't cause pain. That's a bad thing when you have pain. So I did an ultrasound, and she had a cancer in her liver already, halfway between a tennis ball and a golf ball. And for some of you who are surgeons know that if the cancer is over 5 centimeters, I could not get her a liver transplant. She had cirrhosis. I couldn't resect it. She passed away 6 months later, leaving these 2 children. And I was asking myself, why did she die without any access to treatment? She had a treatable kind. She had a genotype 2 infection. She had a treatable kind of hepatitis C. And I said, look, if she had come 8 years earlier, these children wouldn't be orphans. And this was happening to me again and again. We had 2,400 prisoners who had hepatitis C, and not a single one had been treated. And these people were coming to see me. They were dying of cancer or cirrhosis or coming bleeding in our units. So, but the problem was there were 28,000 patients with hepatitis C that had already been diagnosed. This is a reportable disease in the US. I'm sure it's here too. We had their names, but only 1,500 had been treated. There was no capacity to treat everyone. So I developed ECHO with the idea first to get everybody with hepatitis C on treatment in our state. That's how it started. And so how do I do that? So I said, what if I could democratize my expertise in a way that everybody else, because I was having a problem, and some of you may have this problem and some may not, that I said, look, I've become a world expert in hepatitis C. I've published so much on it, but the only people I can help are the people who come to see me myself. That's a problem, because I wanted to have much more impact on the world. And how do I do that? So I developed the ECHO model based on 4 ideas. First was I would use technology, which you now call Zoom, but it is one-to-many video conferencing. and I used whatever was available at that time, Skype and all that. And I would democratize my expertise, but also a psychiatrist and a pharmacist, because interferon was causing a lot of depression. So then the next thing I did is I went around the state of New Mexico and talked to primary care family doctors like yourself and said, look, people are dying in your community of hepatitis C, I need your help. And I talked to 30, 40 people, one would raise their hand, and I went around the state of New Mexico. I drove, and I had no money or no grants, so I had to do it as a volunteer in the beginning. It was just an idea in my head, and I set up 21 new treatment sites for hepatitis C. 5 were in the prison system, 16 were in community clinics all over rural New Mexico, each run by a family nurse practitioner or family doctor. And I gave them my protocol. I said, this is our, we call it American Association Liver Disease Protocol. I gave it to them, said, this is how we do it. They said, no, no, we can't do this. We are not specialists. This is too dangerous a treatment. So then, but that was the second principle, sharing best practices. But since they weren't willing to do it, I asked myself, how did you become an expert in hepatitis C? You were not born a specialist. So when I did my fellowship in gastroenterology in Boston and Massachusetts, I would see a patient and present to my professor, and I would see another one, present to my professor, another one, professor, and after 2 years they said, now you are a gastroenterologist. I said, aha, I am going to use this model to create new hepatitis C-ologists in New Mexico. And the fourth principle was use the internet to track outcomes. So in 2003 I launched my first echo project, and that's what it looked like. It was these Hollywood squares like you see on Zoom, right? All 21 would join on a Wednesday afternoon from 3 to 5 p.m. So I had a very busy practice, so I couldn't devote 10 hours a week, but I said I can devote 2 hours a week to help the community. And all 21 would join, and one by one they would present patients to each other and to my team at the university, which was psychiatrists, pharmacists and me, and we would discuss these, and in 2 hours we would discuss about 8 patients, and then 15 minutes I'd give them a lecture, or my psychiatrist would give a lecture, or my pharmacist would give a lecture on ribavirin pharmacokinetics or whatever. And we did this every week. Every Wednesday 3 to 5 p.m. we would have just this hepatitis C clinic. And to my surprise, or not so much surprise, a system called all teach, all learn came into play. That they were learning as much from each other, because they were bringing one patient to the network, learning on 8 a week, 300 in a year. They were learning from my lectures, my advice, my basically a community of practice had developed, in which I was learning from them, because they knew what the social circumstances were, what the cultures were, what was the barriers to implementation. It's not about a protocol. There are huge problems in implementing a protocol. What resources did they need to build? What training did their nurse need? All kinds of things were talked about, right? In a year they were such experts that the wait in my clinic started falling, and the end of 18 months it was 2 weeks. Anyone in New Mexico could now get this interferon ribavirin, which is a light form of chemo. They could get this treatment in their local community within 2 weeks of wanting it. Over the next many years, we treated 10,000 patients hepatitis C. Of course, I'm a professor and I started doing research. So first type of research I did was to show self-efficacy, and I published this in our leading liver disease journal. It's called Hepatology, where we showed that the self-efficacy of a provider, where we said 1, you have no skill, 7, I'm an expert who can teach others, went from around 2 out of 7 to 5.5 out of 7 on their ability to diagnose, side effect management, treatment of depression, everything under the sun basically went through the roof. Overall competence went up. But we also found that ECHO was producing joy of work for them. By building communities of practice, it was reducing professional isolation, it was increasing professional satisfaction. It was helping the CEOs of these rural clinics recruit and retain doctors and nurses. It was expanding access to treatment. It was doing many, many things. But we also realized what was making ECHO work wasn't just knowledge. It was love and respect and empathy and community building and kindness and democratizing status. In that 1-2 hours of conversation, everybody was equal. A nurse was equal, a doctor was, everybody was the same. We were working around a common mission to serve our community. There is no business model for ECHO. It's purely service project. And so people were finding their mission in life being fulfilled, of service to others, because a lot of people come to the same place eventually in life, that you want to be really happy, you better get your act together and start serving others. So these people had come there and now they were contributing. But all this wasn't good enough that doctors were really happy and satisfied. We had to show that it was as good as a university. So we got a federal grant and we demonstrated in the New England Journal of Medicine a head-to-head study that a prison doctor or a prison nurse actually could get the same outcomes as a university specialist if they participated in ECHO. That was a game changer. Equal outcomes, equal safety, everything was, it was a game changer. In fact, the paper comes out in the midnight in the US. By that time already in the eastern parts of the world, Qatar and all these places, I had emails in my inbox in the morning when I got up, when the paper had been released online, people from the world saying, we want to do this too, we want to do this too. And so essentially that paper set in motion a massive global movement of. So next step was, okay, now it can be used for many things, not just hepatitis C. So the first one we started was diabetes. Then we started one actually for ethics consultation. We started one for, because these rural hospitals didn't have ethics professionals. We started one for asthma. We started another one. Then one after the other we kept starting them. Now we have 70 different disease areas all over the world, but we have about 25 in New Mexico. Childhood mental health, opioid addiction, management of depression and anxiety, HIV, TB, and so on and so forth. As this kept growing, there was one other problem. There were only 2 million people living in New Mexico. And my team and I, so I want to introduce my team here. One of my colleagues is here, Dr. Elizabeth Cluett. Dr. Cluett is my partner in crime and work, and so what happened, she is the chief of staff at the ECHO Institute, and she used to direct our global replication, but now is the chief of staff and helps me manage a team of 200 people full-time in New Mexico, and also we have another 160 in India. And so she's thank you for being here. So our team, we set up this project, a goal. We said we are going to help 1 billion people in this world by 2025. Well, why did we come up with 1 billion? We looked at some very interesting data. 1,800 children die every single day of diarrheal diseases. Most of them are in Africa actually. 1,800 a day. And the missing ingredient is not a radiation therapy expert or an MRI machine or ciprofloxacin. The missing ingredient is the right knowledge at the right place at the right time, without which you can't get the right care. 4,000 patients die every single day of tuberculosis. Maximum is in India, but Africa is a close second. And again, the treatment is pennies, but to make the right diagnosis in a timely way, to get the treatment, have the patient adhere, it's complex. So we realized that 6 billion people in the world don't have the right knowledge at the right place at the right time. So if we really wanted to make a difference, we had to do it at scale, because we asked ourselves that what really is ECHO doing? Okay, after all, ECHO is not a hepatitis C program, it's not a diabetes, it's not a dermatology program. What we are doing is we are giving an organization or we are giving an individual the ability to democratize best practice, whatever that may be, with speed, with scale, with high quality, and at much lower cost, a tenth of the cost. So we won this worldwide competition for $5 million for the most disruptive innovation in healthcare globally. And there were 300 applications from maybe 20 something countries. The reason we won it was because we were breaking this cost benefit equation, that you could get higher quality, more impact, higher speed, and still lower the cost by a tenth, by 90%. So that, I think, is the reason. So we said, okay, if we have this innovation now, 1 billion people, how do we do this? So the first thing we did is, okay, we have to democratize, just like we are saying to Anton, you can democratize your expertise on orthopedics or hand surgery. We said, why don't we as ECHO, our team, democratize our expertise and tools and intellectual property for free to anyone in the world who wants it. So went to the founder of Zoom before anybody had ever heard of it, and he gave me this absolute worldwide license that I could give out any number of, like you were talking about, you have a license of 1,000 people. We've given out thousands of those licenses to people around the world. So we first taught University of Washington, then University of Chicago, then Harvard, then Johns Hopkins, and MD Anderson, and so on and so forth. So we've set up about 300 such hubs. So the American, the oncologist is here, the American Cancer Society, UICC, this is the international body. They are all ECHO hubs, American Society of Clinical Pathology. All of these people work with us. They are ECHO hubs. MD Anderson, Texas, and Memorial Sloan Kettering, and Dana-Farber Cancer Institute. And then in diabetes, we went to Stanford and Joslin Clinic, and all of these, one by one, we started knocking them out, and we now got almost all the major universities doing ECHO. And what did we take for them, and what are we going to bring for you? We gave them the Zoom platform when nobody had ever had it, right? We gave them access to, we created a in-cloud repository of information, which had curricula in it, case presentation templates, evaluation tools, grant writing materials. We said you can have all of this for free, and then we've developed a software called ECHO, which helps you track what's going on. So there is, once we bring it here, if you're willing to accept the new version of our software, that will even issue certificates. So we rolled out this new software in India 5 months ago. It will automatically track your attendance and data for you and outcomes automatically. They have issued 30,000 certificates in 5 months to healthcare providers who've learned on different aspects. But this is not just for specialists. A family physician head can democratize your expertise by upskilling nurses in rural communities. We have huge number of community health worker project ECHOs where the learners are not doctors, but we also have super specialty ECHOs. MD Anderson runs ECHO projects in Africa to train oncologists on special areas like breast oncology or whatever. So the National Cancer Institute runs Project ECHO. So we did this, but most of the people, only 300 million people live in the US. So then we said, okay, anyone in the world who wants to do ECHO, and we have chosen Africa as a focus area for obvious reasons. The need is highest here, Africa as a continent. We partnered with the World Health Organization. We have more than 90 hubs in Africa. So I'll give you a few examples. In South Africa, what are we doing? Stellenbosch is a hub. Wits University is a hub. University of Cape Town is a hub. Your national health laboratories are hubs. Robert Mangalozzi Cancer Center in Kimberley is a hub. And I think there's an African Society of Laboratory Medicine is a hub. So these are the 6 hubs in South Africa. But South Africa is the minimally penetrated part of ECHO, and that's why we're here. We think under your dean, Dr. Dlova, and you, Dr. Ramklas, as leadership, we hope you can be the example for Africa of democratizing the expertise. But one important issue here is that ECHO is not just to disseminate knowledge, it is to democratize the implementation of knowledge and put in effective triage systems in place. That means we are not saying that you don't come to Durban. We are not saying your care should be in the periphery. What we are saying is the right care at the right place at the right time with the right knowledge at the right place. And that serves as an effective triage system that 70% of them or so can be taken care of by primary care, but the other ones want to come here soon. And so what you do is you decompress your waiting list so that seriously ill get care first. In your case in neurosurgery, you only need to see those people who have a high likelihood of surgery or who you need your special MRI scan. It's possible. In the surgical fields, you can't have them do hand surgery there, but you can do pre-op assessments, you can do post-op care, you can train people in cancer. You may not want somebody doing high level chemotherapy there, but you could put in a prevention. Like for cancer, we have smoking cessation echoes and HPV vaccination echoes and HB vaccination and screening for liver, breast cancer, screening for cervical cancer, screening for colorectal, etc., etc., palliative care, survivorship. Survivorship echoes are huge in developing countries because you cure somebody of cancer, but then there is nobody in the periphery who knows how to manage a cancer survivor, and then they have to keep coming back here, which is hard, and they can fall off the follow-up curve, right? I'm sure that happens. So it can be used for many things: headache management, assessment of all kinds of different things. In Kenya, in Kenyatta National Hospital, they basically adopted ECHO, started with HIV, but now they do it for ENT. They do it for lots of other diseases like that, emergency trauma and other kinds of applications. And now they have started a collaborative in maternal health, and I know there is no one in maternal health here, but if okay, hi, nice to meet you. So if you are a middle income country, so this statistic doesn't apply to you, but in low income countries in the world, the likelihood of death of the mother during pregnancy, which is the biggest catastrophe health system can ever face, a young mother dies, the 130 times likelihood of death in a low income country of a woman who gives childbirth compared to a high income country. In South Africa, it's nothing like 130, but it's at least 20 in rural South Africa. It's a problem. So you can do prenatal care, you can do perinatal health, high risk pregnancy management, and all of that with ECHO. It's being done. And child health is huge: autism, child psychiatry. Child psychiatry is a very hard specialty to find. So Kenya launched one hub out of Kenyatta Regional Hospital, and then now in their 16 county hospitals, they're going to put 16 hubs for the whole country. And I think that is possible even in this province eventually, that you be the master hub and then you have sub hubs, so that we can actually help everyone. We have huge projects in Ethiopia, multiple institutions doing that. The African Union and Africa CDC is our partner. Africa CDC has run a 40 country collaborative on implementing global health, international health regulations. WHO Afro is our partner. They use ECHO for all their trainings now. Afri Health in Fatima is our partner, and so, but we have barely scratched the surface. So far in the last 4 years, we've had 3.3 million attendances by healthcare providers in the world in 190 countries, but our hubs are only in 55 countries. We have right now 658 hubs operating out of 55 countries, but we want 1,000 just in Africa, because the need is so much to train community health workers, to train nurses, to train doctors, etc. So really, what makes ECHO work? First is team based care. Second is mentorship and guided practice. So whenever you're dealing with a problem of dynamic complexity, you can't just get a lecture and implement it. You need guided practice. You need a mentor. Our goal is to make every human being work at the highest level of his human potential. What does that require? Many experts helping you, not just one. Case-based learning, guided practice, and mentor-mentee relationships. When you have that, human performance will improve. But the real secret sauce of ECHO, which causes what we call force multiplication, that's the goal. We've defined that in healthcare as an exponential improvement in capacity to deliver best practice, minimum of 10 times. To get to 10 times, the key features of ECHO are, it's a social network, it produces joy of work. As I said earlier, it's love and respect and kindness, empathy, and building communities of practice. That's what makes ECHO work. The role of technology is to dramatically reduce the cost of this thing. What ECHO is not an organization, it's a movement to change the world. And why do we need to change the world? Because the fact is, we cannot have a peaceful world if there is so much disparity. If there is so much inequity in the world, there will always be crime and terrorism and wars and this and that, and we'll find different reasons to explain. We'll say this is religious, this is bar, but inequity leads to this. And there isn't enough money in the world to make everybody rich, but there is enough knowledge. I could take an Anton and do 100x on him with ECHO, and guess what? He will be richer for it. So knowledge has a different physics. It's not a zero-sum game. When we share, we also become richer, which is very different from material resources. If I share half my rand in my pocket, I'm only left with half. But if I share my knowledge, I have more left. So that's why, in order to make an equitable world and meet the UN sustainability goals of reducing poverty and gender equity and higher quality education, we also work in the field of education. We have lots of hubs to mentor school teachers, school principals, math teachers and science teachers and all that. But I won't talk about that because I'm in a medical school. But I'll end by saying I invite you to join us, join this movement to change the world. And there was an anthropologist who said, never doubt the ability of a dedicated team of people to change the world. Indeed, it's the only thing that ever has. So I invite you to join forces with us to change the world and make it better. So thank you for your attention. Thank you.
Okay. Thank you so much, Dr. Prof. Sanjay, for that inspirational talk. I mean, I can almost palpate the passion, from what you are.
I think you need a mic. Yeah.
I have it here. I don't know if it's.
Hear you on Zoom.
It's supposed to be. Is it on? The one on me? Do I need this and that one? Okay. Thank you so much, Professor Aurora Samjit. That was a really inspiring talk that you gave to us. I feel so enlightened and so empowered. And thank God we have people like you, And I was just thinking that initially, looking from my point of view as a dermatologist also, we do outreach, but to a limited extent. But with what you've shared, I think there's so much more that is possible. Most of the time, we would refer our patients to the peripheral clinics and for chronic medication, but then they'd have to travel all the way because the medication is not available there. That would be a limiting factor, that certain drugs are not available there. But what I've learned from what you are saying, it's not about medication, it's also about preventative care, education of the patient, education of the nurses, how to apply the treatment, how to use diabetic treatment, what food to eat, etc., etc. So there are lots. I think the possibilities are really humongous, and each and every one of us here from the different specialties, there is no reason why we should not implement this and multiply it 100 times. Because as I was listening to you, every discipline has something to learn from what you have said and can do something about it. Not just one person who's passionate, but even others. So we really, as clinicians, can't just be clinicians sitting in offices or just in the hospitals. We need to get out there and make many more Professor Heaths, a lot of Dr. Andy Leslie are there, and multiply them many times. So it's really amazing. I learned a lot from that. So it's time now for questions. We're going to take questions from all of you. And after the questions, please ask questions. Let's see how we can expand this and be the pilot for KZN and reach out to our province as well. I'll also ask Fatima to just share afterwards what she does as a WHO representative. Thanks.
I'm going to also invite my colleague, Dr. Elizabeth Cluett, because she's the expert on the replication process. And so, can you please come? Just hold the mic. Okay.
Right, thank you very much. Obviously very inspiring in terms of the work that you're doing and the potential that it has. How do the hubs continue to function? Have you continued to base them on that initial model where everyone presents something, or how do you structure them? Now it's much bigger.
So I think the first principle of ECHO is that we want echoes in Durban and in this province by this university, not experts outside, because only you understand what the local needs are. Getting a US expert there is not going to help us that much, right? And in the all teach, all learn framework, it's really critical that at least half the talking is done by the learners. That's how so we cannot say on ECHO, I love you, okay? So what do you do? By the empathetic listening to your learners, you are showing them love and respect, and that is the key success factor, because unless you can build community, then the knowledge doesn't flow adequately. I mean, you all remember, I remember my classes right from 3rd grade. If I didn't think that a teacher really liked me and cared for me, honestly, I couldn't learn from her. I couldn't learn from him. It was like my brain was shutting off in a sense. And so I think that has to be created, and we do that through empathetic listening. And Dr. Cluett, maybe you could talk about some of those aspects.
Well, I think embedded in your question is also sort of how did the hub sustain over time, I think. And, it's really been phenomenal to me to watch the evolution of this, sometimes there's a program that comes and trains, and there are organizations focused on HIV, for example, so they'll start an HIV program and that'll continue on. But often, like your mind starts working and you're like, we're going to start with this one and then we're going to go to that one. On Tuesday, yesterday, we met with the team from Kimberley, and the lead there is an oncologist, Dr. Daniel Osefefe. And so he, started it for oncology, and then especially when COVID came, they had this infrastructure and this practice and this, culture of working this way. So they sort of turned, pointed their trains in a different direction and started sharing best practice information for COVID and ethics, and they have plans for maternal infant health. So they've been able to use that infrastructure as you're planning, right, to sort of reach out into different areas. Did that answer your question?
And there's one other aspect I want to mention is that there are 2 clear aspects of required. One is a passionate physician like you who says, I will upskill primary care across the state. Without that passion, nothing can happen. So you will be the central. But then you need a Dean Delova, because here's the thing, what's unique about this is you have a professor who internally has internalized the role of this medical school to help the whole province. That's not uniform. I can tell you, I go to American universities a lot, and I've been to some universities in Africa too. A dean has many ways to leave their impression on the world. One could be get more grants. Another could be make my school bigger. Or a third could be that my purpose is to serve my community. Having that a leadership of the institution that actually says that instead of just giving people chemotherapy in this place, if you could help the whole state prevent cancer or launch an amazing smoking cessation program here, that's meaningful to you, the dean, that's essential. Many passionate people are not able to fulfill. I mean, they can do one echo. You know why? You can do it as a volunteer, one echo, 90 minutes a week, 2 hours. But to build a system, you need a leader that can create infrastructure like they've created, to have an administrator, to have IT support staff, all of that, you know. So you need the institution support too. A single person can do a lot, but you happen to have almost the perfect situation here, because you've got inspired faculty like all of you, but you also have a leader who's adopted this vision and mission.
So just as a follow-up question, if you try to create a community of practice that you engage with, that must limit the number of people who can participate, because you can't have 100 on that platform if everyone's going to participate. So if you were doing diabetes, you would need to have 10 different sessions with each of the different hospitals or something like that.
So what would be ideal, right, would be you have, first of all, a person doesn't, when I go to a doctor and say, like, be my mentee, I don't say you have to commit the rest of your life to me, okay. I say, can you commit to join once a week session for 4 months? And then after that, you decide. You can come in as a teacher, you can come in when you have a very difficult case. So I can keep adding to it and adding to it and adding. So that's one approach. The second is, if the demand is too much and you take that on and your province government has told you address diabetes, there is nothing to say that you could not have one endocrinologist doing one on Monday, another one on Wednesday, another on Friday. And then I started with 21, I've trained 250 doctors to treat hepatitis C over time, you see. And then these people, they accept referrals within their community. That's really important. The reason we treated 10,000 is they first treated their own patients, then their own office patients from their colleagues, then everybody in the town started going to them, because you're creating junior experts there, okay. What would you like to add?
Aurora, perhaps it would help for you to just describe the concept of echo, the spokes and everything, just in a nutshell.
Okay.
Yeah, because that will put them in a, you know, a picture that they can understand.
Yeah, sometimes also what happens is there's an emergency like COVID-19 and you have to essentially modify the echo model, because that's why we've given you a license of 1,000 people can join. So if you wanted to get some key information out, right, you want to train every community health worker in this province to prevent falls, teach people how to assess fall risk when they walk, what exercises to give them, an elderly person, the Kegel's maneuver to strengthen the pelvic floor, balance exercises of walking with your feet, you know what I'm talking about. You have these core messages. You can have much larger trainings also, but the ultimate power of echo would be that you would train these 30, 40, 50 people all at once, right, in your community, then they will also go ahead and train their people, and many will create, that's why I was talking to your dean, sub hubs. So your county hospitals will now become echo hubs and disseminate practice there, and so it's a hub and spoke model. So you're the hub and then all these will be your subsidiary spokes.
Yeah, thanks. I'm from obstetrics and gynae. And thanks for the talk. Apologies, I came a bit late. I like what you're saying, which I think most of us will be familiar with what we had earlier in our environment, what was called telemedicine, Prof. Mas. I'm not sure how many of the disciplines are still implementing a bit of that. But what you also are talking about, in my mind, I'm trying to find out which would be the best model if we leave out of here and say, yes, we're going to do your system. Because I can imagine if I, from obstetrics, maternity, want to reach someone out in Nkandla hospital or wherever in the rural areas, and I say to them, I have a schedule every week at 3 o'clock at this particular time. Out there in that hospital and in many primary health care centers, people are not in disciplines necessarily. It's the same doctor. So if I start as ONG and the pediatrician starts and the surgeon starts, we're creating traffic on the other side. The very same people that have to listen to me and give me audience are the very same people that must give every other discipline that intentionally they want to help, but we're going to take time. The alternative model will be where once a week we say this week is pediatrics, next week is gynecology, next week is, and so forth. But then you find that it will take time. If somebody out there is sitting with a gynae case they want to refer, and gynae is only coming in 4 weeks' time. So I'm not sure exactly which would be the better way of really reaching out. And I like what you're saying, that we can actually do more with our outreach and start using Zoom and so forth, electronics and all the advancement of technology. But I don't want us to overburden the doctors out there, and we start something which is going to cause fatigue, because maybe they might buy in the beginning, but the more we demand of their time, the more they're going to say, you know what, I've got a crowd to clear, and I'm not going to attend this tutorial or this discussion and so forth.
Yeah, no, thank you for that question. Very important. I think the first I want to just make one difference between what is telemedicine and what's echo. So telemedicine is usually a one-to-one interaction between either a patient or a doctor on one end and an expert like you on one end. And it's very useful to overcome a geographic divide, right? Patient doesn't have to travel, but it's not a force multiplier. Because if I put you in front of a camera and you see one patient in one rural area of this province, you'll see one less here. After all, there's a certain amount of time. But it's very helpful anyway. We are purely capacity building. I think the second key principle here is that we don't expect one primary care doctor. Maybe you could explain this concept, Elizabeth, about what are we expecting from a primary care? How do they build communities of different?
I don't have a, go ahead.
Okay, I think what happens is that this is what happens. Okay, we go into a community and we say, okay, there are no specialists and they're all trying to come to Durban. Is there one of you who can agree to be mentee for this young lady, and you are committing to come once a week, but you don't have to go to any other echo, but you are slowly becoming the maternal health specialist for this community. But there's another person there, or maybe a nurse practitioner, I don't know if you have them here in South Africa, but they may decide that they're interested in diabetes and interact with your endocrinologist and be mentored. This is not a teleconsultation service that I have a complicated patient, I'll go and show it to this OBGYN. That's not the purpose here. You're trying to recreate yourself in these communities, okay? And so somebody has to commit to you and say, I want to be like you. I want to serve my community with this maternal health expertise, and I will be your mentee. I'll come every week for 6 months. You can even give me a certificate at the end that I've completed your training. I've taken even a written test if you want me to. That is what it is. But you're absolutely right. One person should not do 6 echo clears. Sometimes they could do 2. But if they did 6, they would be learning all the time and have no time to see any patients. That would not be helpful. So, but then what they do is they create self-sustaining communities. That there's a diabetes expert in the community, there is a maternal health expert, there is also a hepatitis expert there, and each has got a different mentee. There's a dermatologist, like dermatology echoes are very popular, because the primary care, so many of their patients come with a skin rash and they don't know what to do with it. If Professor Dluvova can just train them on the basic dermatology, game changer. But that doesn't mean train everybody on dermatology over there, but in every area at least one person should know, so they can be the first stopping point before they come. An effective triage is occurring. When your mentee identifies a person who's at high risk, really high risk, they're going to say 4 days before your delivery date, why don't you move to Durban and sit there, so that there isn't a 3-day travel time in labor. Or you see what I'm saying? Okay. I hope that answered your question. And people adopt echo like fish to water. That's why we've had 3.3 million attendances just in 4 years here. You won't find that much resistance in people wanting to learn from you if you go with a mentor-mentee. But if you say, look, when you have a difficult case come, they're not going to do that because it takes them a lot of time to prepare a case. What is it in for them then? But to be your mentee and develop a specialized expertise, that's a big deal for them.
And I just add, I think what Dr. Aurora is saying about, what the learners want has to be the driving force in this, right? And like all of you, you've chosen to be here, right? And the job of this group is to provide, material that is meaningful to you. Otherwise, you'll just leave, right? And so people will walk with their feet. You really have to be it's not easy, right? You have to work hard to deliver something that's of value to them. And I was thinking we had a pre-conversation where you were articulating the importance of doing an assessment, right? And I just wanted to speak to that for a minute. Dr. Aurora will say often, people come, what echo should I start, right? Well, in our world, in New Mexico and in yours, probably if you did an assessment, you'd find everything's needed, right? So the key then is, where do you have a champion like Dr. Aurora? Where do you have, a passionate person who's going to be able to have that loving sentiment to create that wonderful community of practice, right? But I still think a needs assessment is really important, right? Like, is 3 o'clock on Wednesdays the right time for your community, or are they seeing patients then? I know for a diabetes project that we have, we wanted to teach them, about type 1 diabetes, but they didn't want to learn about type 1 diabetes. And one of the nice things about an ECHO project is, over time, there's sort of, as Sanju says, a loop, a self-completing loop, right? Where you're saying, oh, well, the attendance is going down if I talk about this, and it's going up. And so you have to be attuned and sort of self-correct over time.
I think a key principle, thinking in business terms, the principal customer of yours is not the patient. It's that doctor or nurse in that community. And don't want them to adapt to your schedule, adapt to theirs. Find a time that works for them and teach them what they want to learn and learn from them. That's how we show respect. What do they have to teach you about what to do?
I don't know if it's still working. You need to speak loud. I must speak loud? Yes. Okay, thanks. Can you say that I must speak loud? I must say I forgot to mention Dr. Basil Enika as one of the committees who established this, so my apologies. So are there any questions from the church? Nothing? Okay. I think the other point I wanted to mention also, when Prof. Smith-Van were talking about, we've started telemedicine or teledermatology in our department, and we sort of had a kind of similar but not the same concept, in that as consultants, like 8 consultants, we had a concept where we say we adopt a hospital. So each consultant would be linked to a specific rural hospital, so that the people there have a relationship and rapport with that particular consultant.
Yeah.
And that was our form of outreach. And then following that, we did talks all over the country. We got funding, and we didn't do them only in KZN, but we went to all the provinces and even we got funding for books, dermatology handbooks that they could refer to whilst we are away. So this actually makes it even easy, because now we don't have to travel to Eastern Cape or Johannesburg or Cape Town. We can do this on Zoom. And again, with the dermatology that we're doing with the regional hospital in KZN, we needed a setup, a video connection and everything, and bandwidth, which was a challenge for us. And the technicians, would get sort of interrupted during the consultation. But now with Zoom, it's something that you just need your cell phone, and you need data and Wi-Fi. So perhaps what we may need to do in terms of motivating to the province is to ensure that the hospitals that we engage with, at least they've got Wi-Fi, or they have a room where the doctors can be and be able to link on their phones. And if the Department of Health cannot do that for us, that doesn't stop us. We shall go out there and look for funding to get Wi-Fi in the hospitals. As we always say, let's not what the government or the university will do for us, but what we can do to make a difference. So that's not going to stop us, because we know the challenges that we have at times with the Department of Health. Understandable, so finances, but that should not be a hindrance. Let us talk and see how we can get the corporate sector to assist us. Cyrilla is going to touch on what we have done because we did a needs analysis in terms of what do the people want to hear. And I want to share an anecdote. When we were doing outreach in dermatology, we had a list of the top 10 conditions that we thought are important for the primary health care doctors. And we sent to all the hospitals, saying, we are going to talk on this. Are you okay with this? We got responses from like 10 primary health care physicians. And out of the 10 things that we thought are important and they want to learn about, only 3 were significant to them. So we had to add 7 that they felt they wanted to be taught about. So this is reinforcing what you said. It's not about what we think they should know, but it's about what would you like to know from us? What should we share with you? And again, if you're passionate about this, it's not about, oh no, I'm only free between 3 and 4. That's when I'll have the echo with you. It's about when are you available for me to empower you and assist you, because they are busy. I mean, when I used to do the outreach in Manguzi and all these hospitals through the Red Cross Flying Doctor, you'd have one medical officer with 100 patients waiting in OPD. So we really don't realize how those doctors are working under immense pressure when they have to consult us. And that's why sometimes I feel so sad and so bad when us as specialists in the big cities, when a doctor phones from a rural hospital and say, I'd like to refer this patient for this, and we start interrogating and intimidating the doctor. Did you do this? Why didn't you do this? Did you check the plus? Why are you sending this? That's so bad. That really is so bad for us, because those doctors are working under extremely difficult conditions. Here we've got CT scans, we've got everything. They have nothing. They have to use their clinical acumen. And I always say, even to students, a doctor who picks up a phone to phone you about a patient, that is a consent doctor. And you should go all out to help that doctor, because you could just write a consultant referral letter and send the patient to a particular hospital. But if a doctor picks up the phone and phones you and say, Professor Musa, I've got this patient, please help me, let's not harass them. Let's look after them. Let's help them. Let's make it easy for them to refer those patients to us. Thanks.
Thanks, Prof. Lover. So just to say a little bit, that we've actually developed a survey instrument that we had circulated to over 300, Ishana, 300 odd hospitals in the province. Am I right? Yeah, so we had developed the survey instrument to find out from hospital managers, and then and further down to the HCUs and heads of departments, what exactly were their deficiencies in terms of knowledge. So which areas were they particularly interested in, so that we could actually create this ECHO program that will respond to their absolute need. So while some of the hospitals said, actually we need assistance in every discipline, then others were more specific. So for instance, the rural hospitals wanted more help with ophthalmology or with ENT. And so that was how we were actually gonna get feedback in terms of how we would design the program located here. But unfortunately, we were then stopped in our tracks, because then Department of Health indicated to us that we needed to wait for their policy to be approved first before we continue. So the instrument has been developed, and the moment we get go ahead, we will relaunch. Whilst I'm here, I'd like to ask Dr. Bhavi if he could actually talk to us about how ECHO is being used extensively in laboratory medicine to train registrars. So if you could just share with us, Dr. Bhavi.
Thank you, Sarala, and thanks for that inspiring talk, Prof. So in the NHLS, we've been using ECHO for the last, I think, 5 years. I think for us what was very important is the day-to-day nuts and bolts and the operations. So we have IT person, Richard, and a coordinator, Leah. So they sort out operations, logistics at a national level, especially in terms, I mean, these are operations like bandwidth and internet and hardware and software. You have to have designated people to do that. Then specifically with registrar training, it's again on a mentor-mentee model, where a consultant from maybe Krutiskeer listens to registrar presentations nationally. So in an hour, registrars prepare a laboratory problem emanating from a clinical case and present it to a consultant that has a specific academic interest in that laboratory problem. So that person might be in Stellenbosch or in Wits or whatever the case might be. The other thing with registrar training is I've used it and others have used it as well to prepare registrars for national examinations, part 1 and part 2. So take them through how to study, how to prepare for the exams, written, the practicals, orals, and so on. The third thing we've used ECHO for is registrar portfolios. And I think this has been quite a game changer for us because nobody except your consultant and you as the registrar, it's just the two of you that are looking at that portfolio every 6 months or whatever the case might be. So we took this on a national level. And when the one registrar presented maybe a 6-month portfolio, just a snapshot of PDFs for about 20 minutes, then the other registrars could interact and ask, questions, and it became quite interesting. And then other consultants and specialists could interact to change their way of assessing portfolios, improving portfolios, work-based learning, work-based assessment, and so on. So I think those are the 3 highlights in registrar training, which really became intensive during COVID because you couldn't fly people all over the place. Oh, and the 4th thing was because we have a National Institute of Communicable Disease based in Johannesburg, and they offered a 4-week training program for microbiology and virology residents, registrars. And it's always been so difficult sending your registrar away for 4 weeks or flying them up and down on a Friday and Monday. The cost, the accommodation, the time away from families and children and so on. And then when COVID hit us, ECHO was already in place, and we've been doing the NICD, things like viral hemorrhagic fever and the level biosafety level 4 lab, even with COVID diagnosis in the laboratory at a level 3 lab facility, level 4 lab facility. We've been doing it through ECHO. So the registrar attends according to a timetable, and you get a certificate or whatever for each session, and you do an online assessment through ECHO, and all those PDFs are collected, and you just place it into your electronic portfolio.
Wow.
So yes, it's really been a great for us from an academic point of view, for registrar training especially. But I must say the NHLS has used it for a whole lot of other things. So HR people will use it to train laboratory managers on how to do performance appraisals. IT will train staff on how to use the Oracle procurement system. Finance will train other managers and lab managers or business managers on how to do 6-monthly budgets. So it's got, and there's so many sessions, time management, project management, specimen collection, specimen transport. It's really very wide.
Incredible.
It's absolutely versatile.
Thank
So
you.
thank you so much
No, thank you for sharing.
creating it.
Thank you.
It's nice to meet the founding people.
Thank you.
So do we have any more questions on the chat?
It's from a Dr. Bernadette Bosnell from infectious disease. Dr. Bernadette Gosnell from Infectious Disease wants to know, well, the first comment is we have a toll-free helpline to help with advice. And then she says we are struggling to source hepatitis C therapy to treat patients referred to us. Any suggestions?
You know what they say, to a man with a hammer, you can complete it. Everything looks like a nail, right? So I'm the man with the hammer. So since Echo is like my firstborn child, I would suggest that Echo can be a highly effective way to democratize treatment for hepatitis C. And I'll illustrate with one example. It's from Punjab in India, that there was a postgraduate institute. There is the leading academic institution in the country for postgraduate training is Postgraduate Institute in Chandigarh, India. It's in northern India, it's the state Punjab. And they were treating 1,500 hepatitis C patients per year. But there were 600,000 patients in the state of Punjab with hepatitis C. What they did is they used Echo to empower district hospitals who had no specialists in GI, primary care clinicians. So now they had 22 centers to treat hepatitis C. First thing that happened, diagnosis rates went up dramatically. Why? Because nobody was willing to come to Chandigarh, which is in far away, it's a big state, to get tested, etc. So now people knew how to test. And then they published in the European Journal of Liver Disease, 43,000 patients were treated with a 91% cure rate. And since the publication, which was a year and a half ago, now they have treated 95,000 patients with a cure rate over 90% locally. So one of the challenges to remember when you're dealing with hepatitis C, if a primary care doctor knows that they are not able to treat a patient, they won't diagnose it. You know why? Because if a primary care doctor diagnoses hepatitis C and then tries to call here and gets an appointment in a year, for a year this patient is calling them and bugging them, what about my hepatitis C? Doc, what are you doing? What are you doing? And he doesn't know. So therefore, what is the default? Don't test something that you cannot help. So once you put the treatment capacity in this rural area or in your small hospital, testing will go through the roof. First of all, you'll diagnose all the patients and then you'll treat them, and I guarantee you your cure rates will be over 90%. You know why? Because the same publications have come out from Argentina, from our site, from all over the world, from the country of Georgia in their national program, treated hundreds of thousands of patients. The same exact results occur because of the mentorship model and what we call hand holding that occurs in Echo to create it. So I hope that answers your question.
Yes, thank you.
Okay.
Hi. Good afternoon. Thank you so much for coming through and talking about this. I'd just like to follow on from that question. You know, when you're doing outreach or democratizing your knowledge and people are starting to identify or learn about whatever you're teaching them, the rate of diagnosis obviously goes up, as does the rate of referral. And sometimes if you don't have a sort of baseline level of institutional readiness
Yeah.
to handle that, or even to perform that diagnostic procedure, you can end up with what you've spoken about, which is kind of the sense of futility and frustration from the very people you are now trying to empower. As you're rolling this out, and I'm sure you've got many models to draw from, would you recommend that somebody establishes kind of what is the baseline level of readiness to manage this condition before I start teaching people about it? And you select that which can be managed. I mean, I'm thinking about disciplines such as ophthalmology or ENT, where there are baseline tests that need to be done, but access to those tests may not be available. And we cannot create a system where we're now further bottlenecking into our central service.
Yeah.
And yet those are the very conditions we want people to bring into us.
That's such a lovely question, and maybe I'll take a couple of minutes to address it. I think the first important thing the general experience in the world is that by doing echo in a particular area with providers, referrals will go down by 60 to 70% to the specialty hospital for medical types of disease areas, okay? Like diabetes, this, that, and the other, because you can train. I would not train people on those things where that kind of facility is not available over there. So what you want to do is you want to train them on those areas where the primary missing ingredient is the expertise of the doctor. But for example, training somebody so that they need a PET scanner right away in rural South Africa, that's not the right echo to choose. There are enough things for you to choose where actually the drug is there, the testing is there. What's missing is what's between the expertise. Start with that. But what happens is include your Ministry of Health, or you call it Department of Health, in your echoes, because they will realize when you go and tell them they need this and they need this, they're saying, oh my God, everybody needs 100 things, what can I do? Let them experience firsthand what the needs of those people are. Every case that is presented on echo is a needs assessment. Why would a primary care doctor present a case to you? He has a need. That's the ultimate needs assessment that occurs.
Right.
So that need is being surfaced and shortages are being discovered, and you are trying to understand what is the low hanging fruit where I can put some resource and it will move the needle a lot, that sort of thing. But that only occurs through conversation. What do you think, Dr. Cluett?
Well, you covered most of it, but I'm just going to try to play Dr. Aurora here. And I've heard you say this like 1,000 times. Don't let the perfect be the enemy of the good, right? Don't spend a year trying to figure out what they need. Get going. You are the learner here, and you're learning what they need over time. And I just end by saying, so my husband's a nephrologist who participated in that diabetes echo that I talked about. It was, I'm telling the truth here, right? It was the most fun he would have in a week. He'd come home and talk about it, right? So as the expert, along with an endocrinologist and other people, he was learning so much about what was going on in the rural communities and what they had, right? It was just a lot of fun and inspiring, because physicians, you all are intellectually, you want to, you want to think about new things and solve problems, right? So have fun is the other thing. Don't wait too long and have fun, I would say.
Well said.
I just wanted to also comment on what our virologist was saying, that being a member of SACOMD, the South African Committee of Medical Deans, we have tried to have an initiative where, in terms of teaching, we know that the different universities have various expertise. We could have an endocrinologist here who's the best, and maybe in UCT they are strong in something else. So we have also been sort of discussing an issue where we have, particularly for training of registrars, say on a monthly basis there'll be a topic that will be addressed to share skills and expertise with the registrars to prepare for them for the exams. So it's not like now you are being trained by UKZ only. You also can tap on the expertise of the other professors nationally. And this is even more crucial and important for universities that are still right there where there's not enough expertise. For example, I'm not saying our university is better, but if you look at University of Limpopo, the Walter Sisulu, etc., they still need to write the fellowship exam, and yet they still have to do MEds, but they don't have anyone to support them in terms of their research and MEd projects. And that's something obviously on a small scale that we started with Prof. Gift here with the PhD doctoral academy, because we invited certain universities to join us. But I would like this to use the same ECHO concept to again democratize teachers' expertise to the registrars that were training for different specialties. So we have a program right through the year where they deal with different topics which are part of the curriculum. And then towards the end of the year, they get a mock approach to fellowship exams. This is how you approach a case. This is how you present. Because most of the time, it's not because of lack of knowledge. It is how you present yourself, how you approach everything. So that's something that the Committee of Deans has also appreciated and wants to embrace. So you guys as heads of departments, feel free to approach neurosurgery, University of Wits or Medunsa, and see what you can do together on an annual basis so you can share the skills and transfer the knowledge.
Fatima's leaving, so she needs to stay.
Sorry?
Fatima.
Oh, Fatima, yeah. Thanks. Fatima
Sorry,
Suleiman.
I apologize. I have to leave for my webinar now.
No,
so
sure.
I'm just going to quickly talk about what we are up to. So I'm part of the AfriHealth organization, which is the African Forum for Research and Education in Health. We have now started an ECHO project. The pilots are Stellenbosch University and UKZN. And ours is an education ECHO as well. We're looking at how academic institutions can be resilient in disruptive environments. So using COVID-19 as an example, the flooding at UKZN, and we're specifically focusing on health professionals education, the training platforms, the clinical training, the academic institutions, how we've had to adapt. And we think that hopefully we can bring out best practices that can help any of the other countries in terms of refugee status, war issues, those sorts of things. So we're hoping that that's what's going to happen. And I have to run to present to the AfriHealth community this afternoon in like half an hour about the ECHO project. But I did want to also just add quickly to say that some of the questions that were emanating, we've been part and parcels of some of the other ECHO sessions, the Meta ECHO sessions in Africa, or some of the other education ECHO sessions. And people have been on it for a while. And part of the reason they are on it is, one, they're passionate. But once they finish their own ECHO, they come to learn what others are doing to see how they can then adapt their ECHO hubs and so forth to be able to continue sessions. So even the ECHO hubs themselves are a community of practice. And they end up actually supporting each other, learning from each other, adapting their ECHOs as time goes on as well. So it's not something that has to self-perpetuate by anybody else's intervention. It does that simply because the people feel so comfortable with each other thereafter, and that's very obvious. So I'll stop there. Thank you.
Thank you, Fatima.
Thanks, Fatima. Yeah, I hope you will keep us posted about what you're doing there, so that, again, because what I find in our university, people work in silos. We don't know who's doing what and how. So I hope this will also bring us together. Thank you so much.
I will definitely, and along with me is Professor Brasovich from nursing, so we will definitely present to college.
Sure.
Thank you.
Thank you.
Thanks. Yeah. So seeing that I think we've covered quite a lot, I'm going to ask Cyrilla to do the concluding remarks, then vote of thanks, and then we close.
Thank you. So, Dr. Arora, thank you for enabling our participation on this global network. We're grateful for the ECHO license. So we already have an ECHO license, right? So we have an ECHO license that allows us access, I'm saying it again, to a free Zoom platform for 1,000 participants, monitoring and evaluation tools, technical support, training of the hub team, and extensive resources in the ECHO library. Have I said it all? Okay. Right. So in particular, UKZN specialists are able to enhance healthcare delivery and quality of lives of people in KwaZulu-Natal through this partnership with ECHO and the Department of Health by responding to its off-site outreach policy. We wish you every success in your future developments with ECHO.
Thank you.
Thank you for visiting us. And now Professor Glover will present a token of appreciation.
Where is it? Okay, thanks. Once more, we are eternally grateful for your presence here, and we feel honored. And by the way, in addition to what Cyrilla has mentioned, that data can also be published, am I correct?
Yes, no, we have 439 peer-reviewed publications in the leading journals, and I hope from now on, many will come from here. So that is my dream. Yeah.
And in our world of capitalism, usually nothing comes free, but this man has made all of this free for us. So it's really, it's on our hands to take it up and make sure that we be the example that he has set. And thank you so much for this gift. I'd like to thank you, Professor Aurora, for coming over here and sharing your expertise and experience of ECHO. We are hoping to make you smile in a couple of years to come.
Yes, yes.
And to you, Dr. Kiwet, thank you so much also for making sure this young man here is well looked after during his travels and for the support you have also given him and us. Yeah, we most appreciate it.
Thank you.
And lastly, colleagues, thanks to all of you for making time to come here. I know you are busy, there's surgical slates, there's clinics. Sorry if it took longer than we anticipated. We appreciate your presence, and I'm really looking forward to see each and every one of you implementing something that's relevant in your specialties. If there's anything you need that I can assist with, please come talk to me, and I will make things happen if it's within my control. Thank you to Cyrilla for really organizing this. It was so nice to work with her. Usually I'm sort of a hands-on person. Have you done this? Have you done this? Have you done this? But everything was ready for me to just come here. So Cyrilla, you've been amazing, as well as our lovely Shamla there, and thanks to Kanye as well. Thank you so much, and to our photographers and everybody else.
All right, so thank you, Prof. Glover, but you know, this all requires a team approach. So thanks to our team for organizing this event, Ishana Gangaram, the ECHO Administrator, the Public Relations Office, Smanga Kuzwayo, Kani Kuzwayo, the audiovisual team, Blue Bottle Productions, Panish Caterers, and to all of you for attending. Thank you very much. Before you leave, we will take a group photo for publication in the Indaba. And I've been given strict instructions that we all need to wear a mask for the group photo.
Okay,
But
yes.
Dr. Rara, you can, we'll have to do
No.
a single photo as well.
No, I will
All right.
definitely put on my mask.
So thank you very much.